Hello and welcome to the COVID-19 Vaccination Information Session presented by Dr. Hashana Perera, Clinical Director Medical at the Student Wellness Hub at McGill University. This session was recorded during a live remote presentation for students on January 28, 2021. Please note that information surrounding the COVID-19 pandemic is constantly being updated, and it is recommended to consult government and public health authorities' websites for the most up-to-date information. Without further ado, Dr. Hashana Perera.
It's certainly been an unprecedented time for us all. The information about the virus has come at us at a dizzying pace, and even as physicians, I'll be honest, it's been hard to sort out the truth. We've adapted the way we care for our patients to try and keep up, but to ensure that we provide our patients with evidence-based care. So I definitely sympathize with the challenge of trying to sort out the noise from the truth, and I was very glad to be invited to do just that today. Above the content I'll be presenting, I also want you to take away 2 points. First of all, be wary of the media. Information, especially in crisis situations like these, are not always accurate. Base your own medical decisions and your actions on public health recommendations and the advice of your own medical providers. For example, your family physician. 2, data is very different from evidence. A lot of what we see on the news is data. Reports about this many of this happening or this many of that happening. It's raw. It requires interpretation to determine what it means and what we should take away from it. So be very wary of that. Listen to the science, as you can trust that it's based on evidence. So I'd like to take a minute to acknowledge that McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. So this is what I'll be talking to you about today. Just a little housekeeping note. I want you to ask all the questions you have. Please, please do. You can ask them in the chat. I'll answer them at the end because I may get through it in the slides. And I want to make sure we have time to go through everything here. I don't have a ton of slides, FYI, only about 15. So before we talk about this vaccine, let's talk about why we vaccinate. So one concept I want to transmit. So a virus needs a host to survive. It can't survive without a host. We are the host for the coronavirus. If you want to take an extreme example, if we were to put everyone with the virus, symptomatic, asymptomatic, pre-symptomatic, put them in a room, lock the door, the virus would die out and it wouldn't be there again. I think it's very important to understand that the virus can't survive if it doesn't have a host that can accommodate it, that can take it on. So the simple answer to why we vaccinate is to prevent illness. What's in brackets there, though, is very important. We prevent illness both in ourselves and in others by vaccinating. So public vaccination efforts, they're costly. The government puts a lot into doing this. Public vaccination efforts for transmissible illness aims to eliminate illness in a population by achieving herd immunity. So you may have heard of this before. Simple definition, the official definition, I should say, for herd immunity is the indirect protection from an infectious disease that happens when a population is immune, either through vaccination or immunity developed through previous infection. So what we're trying to say here is that our herd, our community, is what we're trying to protect with vaccinations. We're trying to protect everyone in this herd. Some people in the herd may not be able to get the vaccine. We'll talk about reasons why in the upcoming slides. Some people in the herd may have lesser reaction to the vaccine. And that's why we need to make sure we're trying to protect everyone so that that concept of there's not any new hosts for it to get to happens. So the 2 strategies that are illustrated there is vaccination or developed through previous infection. If we look at the current serological rates, so the rates of what we imagine is the amount of people who've been exposed to the virus globally, we're looking at around 10%. That's not a lot. If you look at the little teal colored box there, what we estimate for COVID-19 is that we need 70 to 85% of the population to have immunity either through vaccination or through previous infection. So 10% to 70 to 85%, there's a long way to go for that. And we've already gone through enough. The WHO also very clearly indicates that the idea of just letting the disease run rampant is not a good strategy because of the damage it can do. So today I'm going to talk to you about the 2 vaccines we currently have approved in Canada. You probably know there's many other vaccines in the pipeline, and this is definitely a more the merrier situation. So we will be very happy to have the other ones when they do come, but for now we have these 2. So the Pfizer BioNTech vaccine and the Moderna vaccines are currently the ones we have. If you want to see here, I believe you can all see my cursor. So this is a bit of a head-to-head comparison. So they're both mRNA vaccines. I'll talk to you in the next slide about what that means. Both authorized in early and mid-December. The ages they were authorized for are based on the ages that were studied in the clinical trials. So Pfizer over age 16 and Moderna over age 18. They both require 2 intramuscular doses. So traditionally, these are given in the arm. Pfizer minimum 21 days apart and Moderna minimum 28 days. That minimum word there is important. And they both target the same thing, the pre-fusion spike protein of the coronavirus. Storage temperatures, you've certainly heard about this. Storage for Pfizer requires very specialized freezers that can get to -80 to -60, whereas Moderna is more -25 to -15. So what we're seeing now as the vaccination efforts are going out, a lot of the communities that are further out, you're seeing getting the Moderna vaccine, whereas things that are more urban communities are getting the Pfizer BioNTech. Now, how this vaccine works. So I'm going to direct your attention to the left side of the slide, that red thing, molecule. It represents the coronavirus. And what we're targeting here is the spike protein. The spike protein is something that's on the outside of the virus that it uses to attach on and get into our cells. This over here depicts what the vaccine, I should say, is. So it is the mRNA. So the mRNA, what is mRNA? mRNA is like the instructions or the blueprint for how to create something. So it's the mRNA, so the instructions for how to create that spike protein. So one small protein of the virus, not infectious at all on its own. It's a fairly inert, benign thing, but that's what it represents. So the mRNA goes into our own cells and uses our cells' machinery to generate an immune response, both in the form of antibodies and T cells. This, if it encounters the virus in the future, hopefully neutralizes it. And that's the idea behind the vaccines. Very important to note, this mRNA just goes into these cells, it does what it needs to do. After 1 to 2 weeks, it degrades. Same thing with the spike protein that it creates. Degrades after 1 to 2 weeks. So this is a new vaccine, and I know there's been a lot of concerns about this vaccine because it is new, questions about it being developed quickly, etc. One thing I want to be very clear about is that we can trust our vaccine development process and our approval processes here in Canada. No steps were skipped in this process. No corners were cut. The only reason we were able to achieve what we have is because the situation required it. We're living in a time that none of us really, all of us would like to put behind us. And so the situation definitely required us to move quickly. So the steps that were shortened are things like sitting on people's desk for 2-3 months, as would happen in other research settings. Okay, so what are the actual development steps in Canada? So first of all, the scientists develop the potential vaccine. Before it goes into human trials, the scientists conduct lab and animal studies. Next up, we get into the clinical trials, phase 1, phase 2, phase 3. As you can see, the phase 1 style trials, they involve tens of volunteers, so not a large group. And what we're trying to establish here is safety. Is it safe? What is a safe dose? And are there any side effects? Phase 2, we get into a larger group of individuals, so hundreds of volunteers. How well does it work? So does it do what we want it to do? Is it safe on a larger number of people? And what is the safest and most effective dose? Phase 3, these are thousands of volunteers. Does the vaccine prevent the disease? And what are the side effects? So just as an FYI, for the Pfizer and the Moderna, we were looking at between 30 and 40,000 people in our phase 3 trials. It's a lot of people. It also was tested globally, so we have a broader range. And the range, as we said, 16 to 18, all the way up until age 90. So that's where we got our data from, and that's where we based our decisions on. So after these trials, the manufacturer submits the application to Health Canada for review. The experts conduct a thorough and independent review of all vaccine data. Very important to note, the approval process requires these conditions to be met. It is safe, it works, it meets manufacturing standards, and the benefits outweigh the risks. Then we go on to distribution and vaccination. So we're here now, and this is also happening. There is ongoing review and monitoring to confirm the safety and to continue to ensure that the benefits outweigh the risks. So for us as physicians, if we encounter a patient that has had an adverse effect, we have to go and report that. It's very important for this process. Now, if we look at the efficacy, the data behind these, both vaccines looked at the same primary endpoint, protecting against symptomatic infection. So those are individuals who have symptoms and then get tested and test positive. It's much harder, as you can imagine, to look for asymptomatic infection because you'd have to test someone every day to be able to get there. So you've probably heard on the news that we don't know for sure that it does protect against asymptomatic infection and spread. It is really important to note that that is the case. So if we look at the efficacy, after dose 1, after day 14, so that's really also an important point. It takes some time. Remember, I alluded to the fact that the 1 to 2 weeks later it degrades. It takes some time for your body's machinery to get things going. So after day 14, we see efficacies of between 89 and 92%. And after dose 2, that jumps up to between 94 and 95%. A great finding that they were able to see was that it does prevent severe infection. And now in terms of how long it was studied. So it was studied to a medium of 2 months post the second dose for the Pfizer BioNTech and 92 days post the first dose for Moderna. So if you do the math there, it's about 2 months post the second dose for both. Why that? Traditionally, we've seen that vaccine-related adverse effects that happen later tend to happen between 30 and 45 days. So this covers us for the longer period, and it's really important to note that this is ongoing. Now, the adverse reactions for these vaccines include the following. So pain, redness, swelling at the injection site, fatigue, headache, muscle pain, chills, joint pain, fever, and enlarged lymph nodes. These are generally transient, last a couple of days, and they shouldn't affect people very much. If we want to compare this to another vaccine, so the shingles vaccines prevents shingles, which is a reactivation of chickenpox. It's not quite the age group of many of the people that I'm talking to today. It's usually people who are over the age of 50 who get this vaccine, but you can see how it compares. It compares quite well in terms of the side effect profile. If anything, it is a little better than this other very commonly used vaccine. Oh, one thing I remember I wanted to note previous. So looking back at the efficacy, oh, I'm not going to go through all that, too many clicks. So looking back at the efficacy, it's really important to note that the efficacy that is provided by these vaccine actually is better protection than the natural infection. We've seen higher and more specific neutralizing antibodies and T cell responses with the vaccination versus individuals who've been infected. So the next question that many of you probably have is, when are you going to get vaccinated? Or when are any of us going to get vaccinated? So the Quebec Immunization Committee has made recommendations on who should be vaccinated and in which order. So my next slide is going to go through this a little bit more in detail. So I'll just quickly go through this. So individuals who are in CHSLDs, healthcare workers, people who live in private seniors residences, people who live in isolated and remote communities. So for example, in the north, people aged 80 and over, 70 and over, 60 to 69, people under the age of 60 who have a chronic disease or health that increases their risk of complications, people who are under the age of 60 and who provide essential services. For example, my daughter's daycare employees were very happy to know that they were on the list, and the rest of the adult population. So for many people here, you may be considered in group 10. So the question becomes when? When? This is what we want to know. So this is where we're at now. So this is data as of January 19th. There's a lot of stuff in here, so take some time to take a look at it. So at the top, we have what is projected. So there's the doses. So hopefully, I'm sorry, this was only available in French. So the doses that we expect to receive. And so this was December, January, February, going on till the end of March. And why do we have this there? Is because the Quebec government has sent the end of March as the target date for when they want to have the first dose administered to the first 6 groups there. The second row is the word I'm looking for over here, is the actual doses that were received. So we were doing really well. We were on target, if not exceeding the targets, until last week. So unfortunately, as many of you have heard on the news, the Pfizer vaccine has hit a bit of hurdle. So the vaccination production in, I believe it was Belgium. I know it's in Europe. I believe it was the plant in Belgium was slowed down. They said that they were retrofitting it to try and produce more. The idea is that it's a temporary slowdown so that they can eventually produce more. It's said that we should still be on track to get to where we need to by the end of March, but unfortunately we had to drop down a little. Now the goal is to try and get 75% of each of these groups vaccinated. If we look at what has been done and what is planned, so green is where we were at on January 19th, blue is what is planned, and this teal here is the second dose. So many of you have heard that Quebec has looked at an alternate strategy for vaccinations. As I said previously, I think this is a bit of a Hail Mary move. It's a desperate situation right now. Never before in my medical life could I have imagined that we would be talking about how we ration care, but this is what we're looking at now. So the idea behind this was to try and vaccinate as many people in the high-risk groups as possible with that first dose, which should get us to an immunity of between 89 and 92%. You're going to say immediately, well, that was that, but then you got a second dose. It'd be very hard to believe that after 2 weeks, the immunity would drop precipitously. Yes, there may be a drop at some point, but I doubt it would be precipitous. If we look at another vaccine that is commonly used, the Gardasil vaccine, many of you may have gotten it in school or may have gotten it even through university, we see that it was studied as a 3-dose vaccine. However, we realize now that 2 doses are adequate, and a lot of communities actually use that strategy, the 2-dose strategy. Only time will tell in terms of the strategy, but it is one that came out because of the urgency of the situation. So right now, in terms of the healthcare workers, we're doing pretty good. It looks like we're on track, honestly, to get to where we want it to be. They wanted to get to 225,000 doses by the 18th of February. And I do believe, I don't know if it's on this slide, but we've already achieved that now. So that's the information there. So if you remember the previous slide, we had 10 priority groups. So it's to have the first groups there vaccinated by the end of April. So the question becomes, when do we think the general public is going to get vaccinated? My educated guess would be May, June, that the general public will be able to get vaccinated. And I would be very surprised that the general public vaccination campaign would have a delay for that second dose. So the delay for the second dose for the priority groups, Quebec has said, will be up to 90 days. And just as an FYI, we're not alone in this. This delay has also been instituted in other provinces. So Ontario and BC is doing the same as they are in the UK. So now let's talk about special groups. So who cannot get the vaccine? If you've had an anaphylactic reaction, so this is a severe multi-system allergic reaction to a previous dose. So the first dose of the vaccine, you have an anaphylactic reaction, you cannot get the second dose. This other group of people who cannot get it are individuals who had immediate or anaphylactic hypersensitivities to any component of the vaccine or the packaging. So the most common would be to PEG or closely related to it, polysorbate. So PEG, anyone who's had the pleasure of having a colonoscopy knows it well, because that's the thing that's in colonoscopy preps, also found in a lot of laxatives. Now, if you look at the data so far, we're looking at a rate of anaphylaxis, and this is using US data with their vaccine surveillance system, of about 5 in a million. We haven't seen any deaths related. Anaphylaxis is a severe allergic reaction, but it is generally treatable. Many people do need to go to the emergency room afterwards. It's natural for a period of observation. Some people have ended up in the ICU, but there has been no more severe consequences related to that. Now, groups in which we have limited information, and this is something that's traditional, it's historic in medicine. These are groups that we studied later. So first of all, pregnant and breastfeeding women. They have different ways of dealing with illness and different concerns related to that. That being said, the Society of Obstetricians and Gynecologists of Canada does recommend vaccination in pregnant and breastfeeding women because the risk of infection is greater than the theoretical and unproven risks that may come from vaccination. And the second group is children and adolescents less than 16 and less than 18, depending on which of the vaccines we're talking about. So in medical school, we learn that children are not just little adults. They're their own little beasts with their own little way of presenting with conditions and its own manifestations. So what we do with children and adolescents, we use what's called an age de-escalation strategy. So currently, there are trials ongoing both with Pfizer and Moderna that look at vaccination in teenagers. Next, we're going to go into children and then younger into infants. So that's a traditional strategy that we look at. We don't expect the data from that to come out until later this year, and then for the group for children, maybe even 2021. So that was all the information I prepared for you. And I was fortunate enough to get vaccinated last week, my first dose. Even through my mask, you can see my dorky little smile. So let's get to the questions. After the presentation, we had several questions regarding eligibility for vaccination. So we wanted to add this just to reassure everyone that vaccination is going to be free of charge for everyone, including for international and out-of-province students.